So thank you. It's a pleasure to welcome you back to the second part of this morning's session looking at sports respiratory medicine. So we've heard already lots about immunity. We've heard about the effects of pollution and ozone. We're now going to take a slightly different tack, but we're going to first talk a little bit about infection and infection in athletes. And I know this will be a particularly popular talk because it's going to be given by Professor Martin Schwellnus, who really is a giant in the field of sports medicine and doesn't really need introduction to many of the delegates who are with us today. He's also an honorary professor at the Institute, and so it is a real honour to have him speak to us today. He's come all the way from University of Pretoria as his main chair in South Africa. And so Martin's going to talk to us particularly about respiratory tract infection in athletes, and he's been involved with leading and chairing a new International Olympic Committee guideline on this area, which I'm sure he's going to mention in his talk, and that should hopefully be published in a series of papers early next year. And so we're really looking forward to seeing what he's got to say. And of course, I've asked him also to talk about COVID-19. So thank you very much indeed, Martin.
Good day. My name is Professor Martin Schwellnus, and it is indeed a privilege for me to join you at the Sports Cardiorespiratory Medicine Conference. The topic of my presentation is dealing with respiratory infection in athletes, COVID and beyond. I would like to start with a few introductory remarks and then focus this particular lecture on a few very specific topics. Respiratory tract illness is the most common acute illness in athletes, and there are multiple epidemiological studies from various settings that have confirmed this. Acute respiratory infections are most commonly the cause of these acute respiratory illnesses. And we know from more community-based studies in non-athletes that they are mostly viral in origin, but they are also obviously bacterial and other pathogens. However, in most cases, and I'll show you some data in a little bit later, the exact pathogen in respiratory tract infections in athletes is not known. And I'm making this point based on the data from studies before the COVID-19 pandemic. A next important point, which we will discuss to some extent, is that most acute respiratory infections would be mild or moderate in severity if they are indeed symptomatic. And hospitalization, which is a severe infection, is rather uncommon in athletes and is probably not the focus of this lecture. The final point as an introduction to make is that the COVID-19 pandemic has really cast the spotlight on acute respiratory infections, obviously in general, but also in athletes specifically. And we're looking forward to lots of research that will come out of the pandemic that will increase our understanding of respiratory infections in athletes. It's also focused the attention on actual pathogen identification. So I will introduce this lecture just with a few slides on classification, clinical presentation of different syndromes and diagnosis. But I'd like to focus the attention based on the presumed audience, mostly on some of the potential clinical consequences or clinical points that are relevant to the sport and exercise medicine physician. And we'll tackle the issue of infections and reduced exercise performance, the risk of medical complications, and then I will finish off the talk with some guidelines and points to make around return to play after acute respiratory infections in general, and some specific points around COVID-19. So let me start off with a few general remarks around the clinical presentation. This is a table that depicts the common symptoms that are suggestive of an acute respiratory illness in general, but also an infection. And broadly, on the left-hand side, we can divide these into localized or nose-throat symptoms, more regional symptoms involving the chest or rest of the head or neck, and then systemic symptoms. And the symptoms on the right-hand side are listed and are well known to you all. Any athlete presenting with any of these symptoms poses the first major clinical question. And the question is whether or not these symptoms are suggestive of an infection or a non-infection. In other words, other causes that can give similar symptomatology. And so the first clinical point here is how can we possibly distinguish between infective and non-infective illnesses? This table is rather busy, but it does take the symptom list that I showed you in 2-3 slides ago, the various regions, some of the common symptoms, and then the last 3 columns, with the middle one being symptoms that are fairly typical of allergies rather than infections, and then symptoms of infections on the 2 right-hand columns, dividing those into the more mild and the more moderate symptoms of an infection. Often in clinical documents described as 2 different clinical syndromes, that of the so-called common cold or coryza, being more mild, and more moderate illness, flu-like or influenza-like illness. I'm not going to go through the symptoms in detail, and these slides will be available to you, but the red depicted text shows you that nasal and nose-throat symptoms that are localized are either common in allergies or in the more mild common cold type syndrome. And chest and systemic symptoms are more common in the moderate influenza-like illness. So once these symptoms have given the clinician a clue, if the symptoms are not suggestive of an acute infection, we advocate further investigation, which I'm not going to discuss any further. On the other hand, if symptoms are suggestive of an acute infection, the following are important to consider. An anatomical difference, we spoke about the mild to moderate syndromes, by distinguishing more upper respiratory and lower respiratory tract symptoms, and try to identify one of 4 clinical syndromes that the infection presents with, ranging from asymptomatic, as I've indicated before, mild, moderate, or more severe. And as I've said, severe are uncommon, and probably I won't discuss that in too much detail. The next consideration is whether this necessitates a pathogen-specific diagnosis, or whether the clinical syndrome is sufficient for the clinician to treat. The one important point we'll come back to is that some pathogens, and COVID-19 is a very good example, can be a pathogen involved with multiple organ involvement. And that would be an important clinical point to distinguish between athletes with different severities of infection. The anatomical classification is well known to us. And this slide just depicts the anatomy and the common anatomical areas, which are usually classified as upper respiratory tract and lower respiratory tract. And again, the clinical syndromes here that I've mentioned before, the common cold or the so-called coryza or nasopharyngitis would be the mild clinical syndromes, and the more moderate infections will result in an influenza or flu-like syndrome, which will be mostly the chest, head, neck, regional, and systemic symptomatology. The last classification can be via the pathogen, and on the left-hand slide are a list of a few viruses, and there are more than 120 that can cause respiratory tract infections. And the common ones that are responsible perhaps for an upper and a lower respiratory tract infection. And these are obviously also vary in geographical regions and in seasons. And on the right-hand side, just not to forget that there are bacterial and other pathogens that can also cause respiratory tract infections. This slide shows some recent data from a systematic review that is currently being conducted by a subgroup that we're working with, formulating the IOC consensus statement on acute illness. And to date, there have been approximately 107 studies that have classified upper respiratory tract infections in athletes by the evidence from clinical suspicion, and really only 4 studies have shown a confirmed pathogen, indicating that the majority of studies to date have used a clinical approach to make the diagnosis, ranging from self-reported symptoms, perhaps with a physician check, or using an algorithm that has been validated such as the upper respiratory symptomatology from the Wisconsin or Jackson classification. And a few studies, about 40 or so, have used physician clinical diagnosis by history examination. So those are my introductory remarks, and I'd like to now move to the real clinical consequences that I would want to discuss for the next 10 minutes or so. And here the issue is that an acute infection, usually in the upper respiratory tract in an athlete, is important because of the exercise that the athlete wishes to engage in, either in training or competition. And the question is whether or not there's an incompatibility between the physiological and the pathological response. This slide just makes a very important point, and that is that there is a multi-organ physiological response when any individual, an athlete for example, engages in a training session or a competition. And it's the point of the slide is really to indicate that almost all the organ systems in the body are involved in this physiological response. So right at the outside of the clinical decision-making and the clinical points that I'd like to make is this slide, which I've taken from a summary published in April last year, and there are subsequent papers that have indicated that a respiratory tract infection, such as COVID-19, can be responsible for consequences and pathology in a variety of different organ systems. In a way, the multi-organ involvement in the infection then being the issue that can affect the multi-organ response to exercise. It's also important to remember that when the host, an athlete, responds to an acute infection, that there are two types of responses. On the right-hand side, in blue, is a non-specific or host response, sometimes known as the acute response, irrespective of the actual pathogen. And this process results in the cellular release of a variety of inflammatory cytokines and cellular activity, which can have consequences on the physiological response when an athlete exercises. These non-specific responses can also result in symptoms that are atypical or common to all infections. So the so-called prodromal symptoms, for example, in infections. On the left-hand side is the response to a specific pathogen. And I've already indicated that this may vary between pathogens and even vary within a pathogen. Some individuals with COVID have got virtually no symptoms, while others develop severe consequences in several organ systems. So it's between pathogens, but also within a pathogen that there can be a variable response. And once again, this has consequences when the athlete exercises and has a variable clinical expression. So there are three problems and three clinical consequences that I'd like to tackle. The first one is the effects of exercise on reducing exercise performance, the effects of infections on reducing exercise performance, the potential for medical complications, and then the clinical decision to return an athlete back to sport or back to training. This is the slide that perhaps just summarizes very little information that we have, really only from animal studies and a few studies in selected pathogens in humans. But it does summarize that acute infections, respiratory infections, can affect exercise performance negatively. For example, decreasing strength, muscle strength by about 10%, altering substrate availability for working muscle, decreasing muscle endurance and general endurance capacity, and even affecting neuromuscular control. And a subgroup, once again, of the IOC consensus group is reviewing this information and will be available towards the end of the year. We have conducted one study to look at the effects of performance. It's an indirect measure of performance, which is the ability to finish an ultramarathon or a half marathon in athletes who've self-reported acute illnesses, mostly respiratory illnesses, prior to the race. And this slide does show that the did not finish rate, in other words, the inability to finish the race, is higher in a group of athletes in green with localized symptoms and red systemic symptoms compared to control, thereby affecting their performance. So we concluded that runners with self-reported symptoms of systemic illness particularly had a two times greater chance of not completing a race. We extended this study and looked at the duration of symptomatology before the race, in addition to whether the symptoms were localized or were systemic. And the slide shows that the red columns, which are systemic symptoms, particularly very close to the race, less than 24 hours before the race, result in an up to 7 times greater chance of not completing the race. These are indirect data to perhaps indicate that an acute infection or symptoms of an acute infection, particularly more moderate infections involving systemic symptomatology, can affect the ability to complete a race or exercise performance. The next clinical question is about the potential for medical complications when an athlete with an acute infection exercises. And again, this is a focus of a subgroup 5 of our IOC consensus group. And this is a slide that shows the potential consequences or medical complications in a variety of different organ systems in an athlete presenting with an acute respiratory infection. And these include affecting the thermoregulatory system, for example, altering the normal set point and increasing the risk for heat stroke. On the top right is a particularly topical medical complication, particularly as we have some data, which I'll share very briefly later, on COVID-19, where the concern is that the pathogen results in viral myocarditis or myopericarditis. And that has obvious potential consequences for acute medical complications. Others include effects on the renal system, gastrointestinal system, and even rhabdomyolysis. This table, more for your reference, summarizes on the left-hand column the different organ systems, the potential for types of pathology in the organ system, and then the actual medical complications. With those in red, in other words, sudden death, acute renal failure, and heat stroke, being particularly important as they are life-threatening medical complications. Do we have any data on the incidence of medical complications in athletes who compete or train with illness versus no illness? And the answer to that is there are very few data. We've conducted a study with some preliminary data, which is not yet published, showing that physician-diagnosed acute pre-race illness in a group of athletes, 193 athletes, resulted in a higher incidence of medical complications in a marathon compared to the control group. And these data indirectly show that runners with physician-diagnosed acute pre-race illness have an up to 2.3 times greater chance of developing a medical complication. I did indicate that I will come back to the myopericarditis, and I would like to refer you to 2 very recent publications that examined the effects of COVID-19 infection, particularly on inflammatory heart disease, in other words, myopericarditis. And essentially these 2 papers or studies from the United States and North American group show that overall, it appears that there's a low incidence of cardiac involvement with COVID-19, and that the current recommendation, which I'll speak to in a bit, is a cardiac triad screening with cardiac MRI if indicated. This leads me into the final consequence, which is about return to play. And a few general remarks are that we do not really have any evidence, and the neck check was previously not well researched. With COVID, we seem to have more data, but these data are mostly for the cardiovascular and respiratory systems. A number of protocols for COVID-19 return to play have recently been published, and there are probably a few more, but it still remains very sparse for other pathogens other than COVID. In my opinion, most of these protocols currently are still mostly based on expert opinion. And this slide just shows one of the first ones on cardiovascular algorithm to return to sport or play after COVID-19, published in May last year, followed by one in August from the American Medical Society of Sports Medicine and American College of Cardiology, and then from your own group in the UK, a little bit later in September, again, a return to play protocol focusing on not only cardiovascular, but also respiratory stepwise progression. In my opinion, there are potential limitations of these because, as I've indicated, there's still very few data, and most of, if not all, are very specific to COVID-19. There are also very sparse data on other organ involvement, and in general, other studies in multi-organ involvement in the literature and COVID, for example, are not in athletes. The other, and I would like to put this just out there, is that the final test, in my opinion, is a return to play protocol that involves an exercise test. So let me give you my 5-step approach. The first step, in my opinion, is to assess the severity of an infection, then do a comprehensive clinical assessment and suitable laboratory investigations focusing on the multi-organ system involvement, not only cardiac or respiratory. And then once the athlete has been cleared from multi-organ involvement or has very minimal or no symptoms, to still perform a graded submaximal exercise test and look for signs of unmasking residual symptoms, and then implementing a graded return to play. For time's sake, I'm not going to spend too much time on this particular algorithm, but this is a summary of those 5 points, where step 1 is to take a good history and determine if this is an asymptomatic or mild infection or a more moderate or severe infection. The mild would then continue with the comprehensive assessment, whereas a moderate infection would involve a little bit further investigation with deeper assessment. In the case of an asymptomatic athlete, either an asymptomatic or mild confirmed infection with mild or no symptoms, then we would suggest an exercise test and monitor for symptoms and a normal response, and only then implement return to play. In a more moderate infection, where the symptoms have resolved, I would say the same applies. And in more severe infections or moderate confirmed infection, where the residual symptoms are still present, a much more detailed step 3 analysis, as I've indicated, with a laboratory and special investigations. And should the exercise test elicit abnormal symptoms or unmasked symptoms or an abnormal response, I would suggest a further investigation. Finally, which athletes do not do well, for example, after COVID or an acute infection? I'd like to talk very briefly about a study that we've just published very recently. In the study, we reported an association between the symptoms and return to play over a 40-day period after the infection. And we compared the number, type, duration, severity of symptoms in COVID-19 infections versus other infections. The first main finding was that there was a cluster of symptoms. And if these cluster of symptoms are present, then the chances of returning to play will be much delayed. The most important symptoms being excessive fatigue, fever or chills, and headache, followed by altered loss or sense of smell, chest pain, difficulty in breathing, and loss of appetite, similarly depicted in this graphic. There was a difference between the athletes with COVID and those without, in other words, with other infections, where there was a significantly longer return to play following COVID-19 versus other infections. So in summary, acute respiratory infections are very common in athletes. The clinical presentation, as I indicated, can vary between pathogens and within pathogens, both in severity and in organ involvement. There can be a reduction in exercise performance post-infection. Mostly this is mild and transient, but we need more data. There is an increased risk of medical complications when athletes return, but once again, very few data. I would suggest a sport and exercise medicine physician follows a scientific and evidence-based protocol to return athletes to training following an infection, and I've given you one. And then the days to return to play after an infection appear to be dependent on the initial presentation of symptoms and severity, as well as the pathogen. In this case, it would be COVID versus non-COVID. Thank you very much for your attention.
Okay, thank you for that. I think in the interest of time and with the program moving forward, at this point, we won't take any Q&A session questions, and I'm sorry about that, but hopefully we could perhaps communicate with Martin down the line if people have got specific questions for him and get those questions to him to try and help you. But I want to move on to the next talk now and introduce Dr. Pascale Kippelen from Brunel University. Now, Pascale, I think, is wrongly listed, unfortunately, in the program as a physiotherapist, but she's a respiratory physiologist and has done some incredible work over the years looking at a variety of different issues relating to asthma, and particularly with respect to airway health, and this interesting concept that actually the airways in some way might be injured by partaking in exercise or sport. And so a lot of her work has been sponsored and funded by bodies such as WADA. She's done work for the International Olympic Committee before and UEFA. So very much looking forward to her thoughts now on what we can do to detect problems with the level of the airway, and also what we can do to protect the airway, which of course is really important in protecting overall athlete health. So thank you very much indeed, Pascale.
So good morning, everybody. And before I start, I'd like to thank the organizer for inviting me today, and especially for James Fell to having me contributing to this session. So my talk today is on airway epithelial injuries in athletes. And what I'd like to do in my presentation is first provide you evidence that actually airway epithelial injury happen in athletes. Then try to understand why that might be the case, looking specifically at mechanical and dehydration stress. Then thinking about what might be the long-term consequences, especially to the health of the athletes. And finally, based on current evidence, discuss what are the potential prevention strategies that athletes might use to actually avoid those injuries from occurring. So in terms of evidence, the first set of data that suggested that airway epithelial injury happens in elite athletes was obtained in Scandinavian cross-country skiers. Based on bronchial biopsies, the author were able to demonstrate that the basement membrane was actually thicker in skiers compared to age-matched controlled, and was not significantly different between those skiers who had a positive bronchial provocation test with methacholine and asthmatic individual. And the thickening of the membrane, basement membrane suggests that repeated airway epithelial injury happened in that population, and probably some degree of airway remodeling happened as well as consequence of chronic exercise in cold environment. Subsequently, those similar results were obtained in elite swimmers. Again, the basement membrane was shown to be thicker in swimmers compared to control subject, and not significantly different between swimmers and mild asthmatics. And this could be due to a contribution of the heavy exercise, intensive exercise, but as well exposure, chronic exposure to a chlorinated environment that might lead to airway remodeling, airway inflammation, but as well in this study it was shown that goblet cells hyperplasia and mucus expression actually increased as well. Now, this is a result of chronic exercise. What happens after acute exercise? Well, this is demonstrated in another study here, done in RUNNE, road runner, sorry. And in this study, what was shown is after a half marathon, there were more apoptotic bronchial epithelial cells in induced sputum, no matter what time of the year the half marathon took place in. And in this study, interestingly as well, the author used an indirect marker, non-invasive marker for airway epithelial injury, which is a small protein, CC16. And this protein is secreted by club cells, or previously known as Clara cell. And those cells are located in the deepest part of the airways. And those cells secrete CC16. And when the epithelium is intact, CC16 remain in the lumen side of the airways, whereas when the epithelium gets damaged, it penetrates and goes into the bloodstream and then ultimately is excreted in urine. And following the half marathon, what the author showed is actually that you had an increased concentration of CC16 in the bloodstream that is, again, consistent with at least transient damage to the airway epithelium. Now, with my previous PhD student, Claire Bolger, we use the same methodology to actually demonstrate that it's not so much the exercise itself, but the hyperpnea that comes with exercise that is responsible for this transient damage to the airway epithelium. And we carried out a study in 50 female individuals, trained and untrained, with and without exercise-induced bronchoconstriction. And in all of them, we were able to actually show that the concentration of CC16 increased in urine after 8 minutes of hyperpnea of dry air, which really suggests that it's the trigger for the airway epithelial injury. It's the high ventilation level, not the exercise per se. Now, why that might be the case is probably because of a combination of two factors. One being the high level of mechanical stress that the airway are exposed to when actually individuals generate high flow rate. So athletes might reach 150, 180, even 200 liters per minute of ventilation, and that creates a lot of mechanical stress at the surface of the airways, which when repeated could potentially lead to death and injury to the epithelial cells. Combined with that mechanical stress, dehydration stress is also likely to happen when athletes exercise at high intensity. And this is due to the fact that when large quantity of air are inhaled, basically it takes more time for that air to be heated up and humidified to 100% humidity before it actually reaches the alveoli. So it means there is a significant amount of water loss that happens to the deepest part of the airways. And this was initially shown and through some mathematical modeling and shown that even for only ventilation of 60 liters per minute, which is relatively low, basically already some significant water loss happens to generation 8 to 12 of the airways. Now with Sandra Anderson, what we proposed is in terms of what that kind of injury might lead to a long term is if you have airway epithelial injury, you will have as a response to repair the damage, you will have microvascular leakage and exudation of plasma. And when this process of injury and repair happens over time, many times, it will change the contractile property of the airway smooth muscle, rendering it more responsive, if you want. And that means, especially in athletes who are allergic, is they will on regular basis expose the smooth muscle, the airway smooth muscle, to allergens, and the body will respond more highly with an inflammatory response to those allergens, and this over time can explain late development of exercise-induced bronchoconstriction. In those athletes who are non-allergic, for example, athletes, especially winter athletes exposed to cold, dry air, because airway epithelium is damaged, basically when they are tested in the lab with bronchial provocation challenges with methacholine, the pharmacological agent will penetrate more easily at a subepithelial level, and a lot of those athletes will then be positive to this kind of test. And this is actually very much in line with the data we have regarding the prevalence of asthma in athletes. We know that asthma is a #1 chronic medical condition in elite athletes, and this includes asthma when we look at not asthma per se just, but as well asthma and exercise-induced bronchoconstriction and airway hyperresponsiveness as a whole, if you want. And the overall prevalence is about 8%. But if we look at this graph, we can see that actually in some Olympic athletes, athletes who are more prone to asthma-like issues are the ones who ventilate the more when they train and compete. For example, triathletes, swimmers, or cyclists. Whereas athletes who engage in more explosive kind of sport, where the ventilatory demand is very low, they don't suffer so much from those kind of problems. Now, if we assume that dehydration is a key factor leading to those injury, basically it means that if we prevent this dehydration of the airways, we should be able to prevent airway epithelial injury from happening. And this is what we tested with Claire. And what we did, we had athletes who exercised either in a cold, dry environment or warm, humid environment, and we collected their urine to check concentration of CC16. And as you can see, we're able to actually significantly reduce the amount of CC16 in urine after exercising in warm, humid air, suggesting that inhalation of warm, humid air at least partly prevent airway injury from happening. Now, obviously, athletes cannot choose often where the competition takes place and the environment in which they train. So changing to warm, humid air is not always an option, but there are alternatives. For example, face mask or heat and moisture exchanger exists that athletes can wear, especially when they train, that could potentially reduce the degree of airway epithelial injury. Now, at the present time, there is no evidence that actually that really happen. We know that a face mask significantly reduces the severity of exercise-induced bronchoconstriction, but whether or not airway epithelial damage are prevented or limited is still to be established. Now, the other thing we looked at is whether some asthma drugs in our drug can prevent occurrence of those injuries. And this is work we did with Andy Simpson, and where we pre-medicated athletes with exercise-induced bronchoconstriction with either short-acting beta-2 agonist, terbutaline, or a placebo before hyperpnea of dry air. And we were able, as we expected, to completely block the bronchoconstriction with the terbutaline, and at the same time we're able to demonstrate that actually the extent of airway epithelial injury was reduced when we look at our marker of damaged urinary CC16. Now, what I'm not saying here is that we should prescribe and recommend athletes to use terbutaline or any kind of short-acting beta-2 agonist before they exercise every time to prevent those injuries. Because we know that chronic use, regular use of a short-acting beta-2 agonist can actually have some side effects and increased tolerance to the drug and can actually make the bronchial hyperresponsiveness worse. So that's not really a viable option in practice to prevent airway epithelial injury. Really, the work that should be done probably at the present time is to look at what is the potential for inhaled corticosteroids to actually reduce those airway epithelial injury. In asthma individual untrained, there is some limited evidence that potentially corticosteroids can have a modest effect on airway remodeling and could have an impact on the health of the airway epithelial cells. But what we know from studying in athletes so far is that actually inhaled corticosteroids, when used daily, don't really make much of a difference on airway hyperresponsiveness to methacholine in skiers. And if we accept that airway hyperresponsiveness to methacholine is an indirect marker of airway epithelial injury, those earlier findings are not very promising. Now, other intervention that athletes could potentially use, a bit like inhaled corticosteroids, there might be a potential for omega-3 fatty acid supplementation, especially through a reduction of the inflammation of the airways to reduce airway epithelial injuries. There is some evidence that this kind of supplementation may work in reducing airway inflammation and reducing severity of exercise-induced bronchoconstriction, but there are as well contradictory findings, and there are no data directly on the effect of this kind of supplementation on airway epithelial injuries in athletes. Same story if we look at data for potential for vitamin or antioxidant to limit the extent of injury. There is not much out there, and there are contradictory evidence, so a lot more work needs to be done before we can recommend this kind of intervention to prevent airway epithelial injuries. The best recommendation at the present time is probably to tell athletes to reduce as much as possible, whenever possible, the exposure to environmental sensitizer, like, for example, pollutant, allergens, or air irritant. We talked about chlorine earlier on, but that's obviously not always feasible. So, conclude, what we can say is yes, acute and chronic high-intensity endurance exercise leads and is associated with airway epithelial injury. Those injuries are most likely the result of a combination of mechanical and dehydration stress to the airways because of the high ventilatory demand that are associated with exercise. The repeated air injury repair of the airway epithelium is likely to contribute to the high prevalence of asthma and airway hyperresponsiveness and late development of exercise-induced bronchoconstriction in elite athletes. But really, more work needs to be done so that we can find suitable strategy to prevent those airway epithelial injuries in athletes. Okay, thanks very much for your attention, and I'm happy now to answer any questions.
Well, Pascale, thank you very much indeed. It's a fabulous talk, and obviously describes and illustrates the huge amount of work you've done in this field. I suppose I might start while I'm waiting for delegates to send through questions. And a controversial issue is whether swimming causes asthma. And often one that I'm asked, people say to you, well, you know, asthmatics are often encouraged to partake in swimming, but actually, is it causing asthma?
That's, yeah, a good question. And I think It all depends. Are we talking about just recreational swimming, going a couple of times to the swimming pool, or are we talking about elite swimming, you know, and spending 20 hours plus in chlorinated environment? And some study, I know that the group in Belgium highlighted that especially children who go to the swimming pool potentially are more at risk for asthma, but that hasn't really been confirmed by other groups. So in terms of you know, risk versus benefit of swimming in recreational swimmers, I think the balance is still it's more beneficial. The risk to develop asthma as a consequence of jumping twice in chlorinated environment swimming is probably outweighed, if you want, by the benefit of the activity in terms of physical health. Now, when we think about elite swimmers, that's a different story, because they spend a lot more time in the pool and they ventilate at far greater level. And that's where actually, you know, there is more evidence, especially all the work that the group from Louis-Philippe Boulet has done, Valérie Bougot, you know, repeatedly showing that actually in those athletes, there are evidence that there is inflammation, there is remodeling, and yeah, asthma prevalence is much higher than you would expect, and if you compare to other sport or control subject.
Okay, great. So some questions coming through from delegates. What do you think about the potential place of a nasal breathing pattern or a nasal predominant breathing pattern in protecting the lower airways? Do you think, I mean, there's a vogue to try and help athletes breathe in that way, even during very intense exercise, which I find incredibly hard myself when I try it, but what do you think?
Yes, well, based on very, very old work that has been done looking at how much air actually comes through the nose and contribute to total ventilation when you exercise. When you reach ventilation level over 30 liters per minute, spontaneously you switch to mouth breathing, and the resistance in the nasal passage is so high that actually it won't contribute so much to the total amount of air that needs to go in to actually bring enough oxygen to the active muscle. So even if you increase slightly the amount that goes through the nose, that's not going to make a huge difference to the 100 liters of air that are needed when you exercise intensively. And that's why I think when athletes were starting using patches, nasal patches to see, and you saw it a lot in cyclists during Tour de France and so on, and as the findings it showed very little difference and evidence that actually it makes any difference here, and it might be just a placebo effect because athletes think their breathing is changed when actually it doesn't make much of a difference at all.
Okay. And so in terms of protecting athlete health, do you think there's a role potentially for inhaled corticosteroids in preventing future development of EIB or asthma? So for instance, some might say, in young swimmers who are spending, many hours in the chlorinated environment, maybe taking an inhaled steroid might protect them from subsequent development of EIB.
Wouldn't go there at the present time. We don't even know if if really it works when athletes have established inflammation and remodeling, and so using it as prevention, especially in young athletes where we know that there is always the concern about corticosteroids. What does it do to the health, bone health, and and the side effect potentially. And the issue as well is with athletes, if you ask them on a daily basis to use a drug for something they don't suffer from, what is the chance that they will actually adhere to this kind of medication? We struggle enough when athletes have asthma, established asthma, for them to actually adhere to the treatment. So let alone somebody who doesn't have any issue and tells them, oh, you need to take that twice daily. I think, the evidence is not there, and practically, I think, it's just, it's not going to work, or that's my feeling.
Okay, yeah. And so lots of questions coming through, which is always great to see. So, I mean, there's obviously going to be the logical questions about chlorine and chlorine exposure. And, you know, if we think about this whole morning session about protecting health of athletes, you know, there is something potentially about us thinking about the environment that we expose our athletes to and doing better, let's put it that way. Do you have data on chlorine levels, or has there been a reduction over time? What's been done about that?
Well, the thing is, it varies. Some studies have been done, you know, in different countries, and regulation about chlorine vary a lot between countries. And what is really important, and that's has been shown, is it depends of, for example, the level of ventilation in a swimming pool. Is it low ceiling? Is it high ceiling? How well the ventilation is, and as well about the hygiene of the swimmers. Okay, so in some countries, for example, there are very strict regulation where swimmers have a shower and actually clean themselves before going in the pool, because it's actually a reaction between body fluid and the chlorine that is responsible for the release of chloramines that are actually irritant for the airways. So if swimmers jump in the pool and, you know, get ridden of the sweat and, you know, dead skin, that will limit production of chloramine. So, and as well, variation depending on the number of people actually in the pool at a given time. There is as well variation of the level of chloramine that sit just above the surface of water. So those are all factors that, you know, can be changed depending on how well the pool is maintained and what people do before actually going in the water.
I think that's an important point, isn't it? So when you go to the municipal pool and you try and sneak past that little sort of very cold bath of water with sort of floating plasters in it, you know, you actually do wash yourself before you go in the shower. Otherwise, you're going to harm the elite athletes who are in the lane at the other end of the pool, flying up and down and cause them airways problems. Do you think over time, this, you know, there might be a risk of remodeling, and what kind of performance impact might that have? Are we able to characterize that or put some sort of objective handle on it for people who are working with athletes and the impact on their performance from this?
Well, it's really hard to quantify actually what the impact might be. I know that John Dickinson has done some work where he gave some corticosteroids after he identified athletes with VIB, and there was some evidence in this paper, even though it was on a small pool of athletes, that their VO2 max post-treatment with inhaled corticosteroids was improved. But in terms of there was some issue. It's not a long term, and, you know, and it's small sample. So, but, you know, you can imagine usually when athletes come to us is because they really struggle with their breathing, and that feeling of breathlessness or chest tightness is likely, you know, to impact on maybe how hard they try, or, you know, and so might indirectly reduce their performance. Now, having said that, if we look at data, if we compare in Olympic Games, you know, who won most of the medal, and, you know, the percentage of medal won by asthmatic athletes, they outperformed, you know, non-asthmatic athletes. So there is this question: is it because, you know, is that anything to do with the drugs they are taking to treat their asthma, or is it because they have this medical condition that they maybe push themselves slightly harder to try to make up for the potential deficit that they see they have because of their medical condition? So, yeah.
Okay, thanks. And so I suppose another point is, you know, another environment that people face, that especially winter sports athletes, is that very cold, dry air. And you've showed some data from the cross-country skiers and epithelial damage. And there's a question specifically from the delegates. Do you think, you know, an acclimatization process in some way allows the airway to respond or protect itself over time to that type of insult or injury? I know, you know, use of bronchodilators is very prevalent in cross-country skiers, for instance. Are we simply opening the airways to further damage as well, or what do you think about acclimatization in that context?
it's hard to say because I'm not aware of any studies that have looked in human at repeated bout of exercise in cold, dry environment, what effect it has on the health of individual. Now there are some data in dogs. Alaskan sled dogs, and that show, for example, when they take part to multi-day races, basically by the end of the race, the airways of the dogs are completely inflamed, and there is the same kind of changes, remodeling, injuries that are present after a long period, or several weeks of day in, day out exercising cold, dry environment. So that suggests that, yeah, I don't know if really exposure, if you can have an acclimatization or effect, I'm not convinced that will really happen.
I think it was interesting what Mike Cole was saying earlier on about some historical data showing some form of airway or spirometric evidence of acclimatization to ozone previously. So, I mean, those studies would be fabulous to do, wouldn't they? There's a question specifically about ozone in water as a disinfectant instead of chlorine, and I don't know. There is some data about indoor and outdoor pools, but is there data about ozone and airway health?
Not used as disinfectant in the pool in athletes, I believe. Now, one study that has been done looked at see if athletes do open water swimming versus indoor. So and if I recall properly, there was not much of a difference, I think. The problem as well in seawater, then you add another component, which is salt. And salt itself might impact on, the osmolarity of the airway. So you might add something that you don't have in indoor pool, in seawater, that confound some of those effects. But certainly a comparison between athletes who train in pools that use alternative to chlorine would be versus a chlorinated, disinfected pool would be very interesting to run. But there are not so many of those pools here in the UK, for example, and so it would be very difficult to get those data, unfortunately.
Yeah, and I think military pools and those pools within the services are often not non-chlorinated methods of cleaning, so they've obviously clued into this damage potentially in the military personnel. So listen, time for one final question, I think, which might be slightly controversial, but why is salbutamol MDI inhalations banned 30 minutes before competitive swimming?
Why is it banned?
Yeah, that's from a delegate here who's asked about them. Why can't you use an inhaler 30 minutes before competitive swimming?
I'm not aware of that rule. Are you aware of that? I never heard about that. So it's a maximum daily dosage that is regulated by WADA. But in terms of timing, and I'm not sure where that comes from, because it's usually what is recommended if athletes have asthma is to take the drug roughly 10-15 minutes before the event. So I'm very surprised by that, and I would be very interested to know who else decided about this regulation, because it seems like against what is recommended when using salbutamol or short-acting beta-2 agonist prophylactically before exercise to protect against exercise-induced bronchoconstriction.
Yeah, okay, for sure. Well, listen, I mean, thanks also for the delegates for a fantastic question, but a special thank you to you, Pascale, for what has been a great talk and a Q&A. And I look forward to seeing more of your research coming forward in this area. I would say for anyone who's really interested in this, Pascale's got some fantastic editorials and commentaries within the BGSM series that really does tackle every aspect you'll want to know about airway injury. So thank you, Pascale. I'm going to just close your
Thank you very much.
Matthew. And for this last component of this morning session before the lunch break, it is my great pleasure to welcome Julie Moore, who is our respiratory physiotherapist here at the ISEH. And Julie's very, very well known within the field of respiratory physiotherapy. A lot of her work more recently has been focused on COVID and helping people recover from COVID. And she's been running a number of long COVID clinics remotely and in person. She does a fantastic job with helping people recover, but does a fantastic job here helping athletes with their breathing. So I'm going to hand over to Julie and we're going to hear what she has to say about helping athletes breathe better. Thank you very much.
Hi, my name is Julie and I'm a respiratory physiotherapist here at the Institute of Sport, Exercise and Health. And it's my role to teach athletes how to breathe properly, breathe correctly. Believe it or not, yet they can breathe very badly. So I want to be able to talk to you today about how you can help your athlete to breathe better, to really optimize their respiratory performance. So I suppose the first thing is to think about, have you actually ever considered about how well your athlete breathes? And so what I want to explain to you today is, why does that matter? What are the consequences of a poor breathing pattern, and how you can ensure that they breathe well and have a good breathing pattern? So up here at the Institute of Sport, Exercise and Health, we have athletes referred to us that are complaining of breathlessness, chest tightness, unable to complete their training sessions. And so it's absolutely essential that they go through, fairly rigorous investigations to establish what might be causing that. There's often a presumption that there's a physiological reason for this, and there often is, but sometimes there isn't. And the team up at the ISEH, we're performing spirometry testing, EVH testing, pheno, CPET testing, and it really allows us to get an accurate diagnosis so that we can then provide the right management. So what we find is that some athletes don't actually have a physiological problem, and that the symptoms they're experiencing is actually due to what we call a breathing pattern disorder, or in the literature it's sometimes called dysfunctional breathing. And what that means is basically the athlete is, the person is breathing biomechanically really badly. And what that can lead to is the symptoms of the breathlessness and the chest tightness. They might also be breathing slightly in excess of their metabolic requirements, which can cause absolute havoc and can also affect performance. So it's absolutely essential that we get a thorough investigation and an accurate diagnosis. So for me to be able to explain to you about how to get your athletes to breathe better and recognise it, we've got to go back to basics. We've got to go back to looking at breathing at rest, first of all. So let me take you through a good breathing pattern. Okay, and it starts at the nose. The nose is absolutely essential to warm the air, clean the air, moisten the air. Now, I know athletes don't necessarily breathe through their nose while they're training hard, but when they're not training, this is at rest, it's absolutely essential that they're breathing through their nose as much as they possibly can. And we know that athletes struggle with allergies or certain environments like swimmers. They often do have quite a lot of nasal issues, and it's really important that they are treated, because a good breathing pattern starts at the nose. It ensures that the diaphragm works well and there's a nice movement of the rib cage. And really, you should be breathing, we should all be breathing pretty much through our nose 95% of the time. So unless you're eating, talking or exercising, you should have your mouth shut. And I have great pleasure in telling athletes to keep their mouths closed or shut their mouths. But also, another big problem that we see is athletes that breathe in a very upper chest breathing pattern, and it's where they're not using their diaphragm properly. Diaphragm, that lovely dome-shaped muscle that sits at the bottom of the lungs, contracts down and there's drawn into the lower part of the rib cage, which is absolutely essential for good ventilation, perfusion match. But it often comes into this upper chest breathing pattern, and that in itself can cause all sorts of issues. But also what we see is that the volumes of the tidal volumes can often be quite large. So, you know, tidal volumes at rest are really quite small. They're only, you know, sort of roughly 500 mils. So when I can, sometimes when I'm looking at an athlete's breathing pattern at rest and I can actually hear the air coming in and out, that sort of often tells me, if I can hear it on the in, there's probably slightly a bigger volume of breath. If I can hear it on the out, that can often indicate that the rest rate is a little bit fast and the person's actually forcing the air out to get the next one in. So looking at their rest in, rest break, you know, and it is just as little as 10 to 12 breaths per minute. And often I think we lose sight of that when an athlete's doing a lot of training where they're breathing at high minute volumes. You know, are they actually coming back down afterwards? And I think some of the reasons why athletes get these breathing pattern disorders is due to sort of habitual bad breathing. So, you know, the trigger could be absolutely anything. It could be due to the nose, it could be due to stress, it could be, there's a number of things. And often the initial trigger then creates an abnormal pattern and then the pattern becomes habitual. So I think probably this is the really good opportunity for you all to just check your own breathing pattern out. So if you can assess and look at your own breathing, then you can look at someone else's. So just have a go. It takes less than a minute. Put one hand on your upper chest, just as I'm demonstrating there, one hand on your tummy, and just see, as I'm doing this lecture now, are you able to sit with your mouth closed, breathe through your nose? What can you feel? Can you feel that the tummy rises and falls? So as the diaphragm contracts down, it pushes the tummy out, comes back down, nice and relaxed. No movement of the upper chest, and your breathing is quiet. And in actual fact, you get a nice breath in, nice breath out, and then there's a pause. There's a pause between the breaths, and often people lose that pause, which is really important in getting a good, efficient breathing pattern. So hopefully you're having a little feel for your breathing pattern now, and I would imagine some of you are probably quite surprised at perhaps how you're not breathing quite as well as what you should be. So that's really important, but obviously we want to look at how the athlete breathes during, you know, while they're training, while they're exercising, while they're performing. And what I want to sort of demonstrate to you is you know, the biggest thing I think you can do is actually to listen to the breathing pattern. You can also watch. You can watch what happens, you know, with the inspiration through the mouth. That can sometimes be challenging, you know, in certain positions, cyclists and riders. So sometimes listening is the most essential, one of the real sort of key ways of recognizing this. And I'm going to just play something now that it's going to give you a little bit of an idea of what I mean by a sort of fast inspiratory gasp, which tends to be in the upper chest. So can you hear that gasping sense, you know, that gasping sound where the breath is being driven into the top part of the chest? They're really not getting a good diaphragm contraction. Or here's just another one for you to have a listen to as well. And you can start to hear the tightening of the throat, which is actually reaching for her throat there. And this is really common in athletes that experience that exercise-induced laryngeal obstruction, where there's so much tension, so much predominant movement in the upper part of the chest that there's a lot of tightening, and the throat, you know, the muscles in the throat, you know, they're very good at closing down, it's a protective mechanism, which is absolutely important that we correct the breathing pattern with those athletes. So moving on to this next slide. So what's really fascinating, this was a paper that was published earlier this year in January, and it gave us a really nice sort of visual presentation of 5 different people going through a CPET test. So what you've got here is you've got breathing frequency on the left y-axis, and you've got tidal volumes on the right y-axis, and then you've got minute volume going down the bottom, and the multiple plots help you to sort of guide what's going on there. Now A and B are kind of your ideal patterns, where initially the tidal volumes get bigger, and then as they plateau, then it's the rest rate that carries on getting faster, and there's a nice pattern there. But what you can see in C is that in actual fact that initially the person is breathing very badly, rest rate is rising really quickly, and then it starts to match. And I often see this in people that have breathing pattern disorders at rest, but then when they exercise, they actually feel better. So it doesn't tend to be the athlete, but that's presenting to us, but we do, this is quite a common thing. So it's nice and interesting in your subjective history. I say to them, how does it feel when you exercise? And so as the person actually gets a balance in their, a sort of match in their metabolic requirements, it can actually feel a little bit easier. Then you've got D, where it's right at the very beginning, and sometimes that can happen where there's a bit of performance anxiety. You know, the anticipation of exercise and performing can wind things up a little bit, and then it's not until they get into the training session that things settle down. And then the last one, E, can you see the erratic nature of the volumes of the respirate there is just all over the place, and this is really common what we see in athletes when we're CPAP testing. Then they've got fast upper chest breathing patterns, and this is a big source of them not being able to continue to exercise and impairing their performance. And so the reason for this is that when the diaphragm is not in a good biomechanical position, it changes the volumes and pressures. And what tends to happen is when the diaphragm is not able to work through its full range of movement, and as I say, this very much predominant upper chest breathing pattern happens, the respiratory muscles start to fatigue. And then what this reflex does is it sends messages up to the brain, sends messages down to the lower limb muscles to basically steal the blood from the lower limb muscles to get it back up to the respiratory muscles. And so the sensation that the athlete will be feeling is not only breathlessness, but they will get a sensation of this fatigue and not being able to complete their training sort of sessions. And so the thing from this slide is basically the respiratory muscles will always win over the lower limb muscles. And so it's absolutely essential that we make sure that the respiratory muscles are working biomechanically well for the athlete to really get the most out of their performance. So how to get your athlete to breathe optimally while they're exercising? Well, one of the real simple ways that I help athletes is just even preparing for exercise in terms of making sure that they are, you know, using the nose to help control the breath, control the volume, control the rate before the exercise intensity gets too much. So they might be able to keep their mouth closed for a period of time during the warm-up. Once the exercise intensity rises, that you're going to lose that, and you're going to find that the volumes are going to get bigger and the respirate is going to get faster. So you might find that they breathe in through the nose and out through their mouth, and that might be for a period of time. And as the intensity increases even more, that's when they'll be breathing fully in and out through their mouth. And then you can do the reverse as they're sort of coming down and cooling down. But when they're at that peak of the exercise, that's the bit where we've really got to work on getting the athlete to really look at taking the inspiration where it's coming down into the lower rib cage. And we work a lot on getting a nice biomechanical, smooth action of the rib cage so that the whole of the lungs are used properly, rather than that predominant upper chest and those lower parts of the ribs not really moving very well. So things like breathing into your lower rib cage, breathing into your armpits. I might put a bit of exercise TheraBand around the lower ribs to give a little bit of feedback, or use the heart rate, you know, the strap possibly. Any techniques that helps the athlete to guide where the breathing goes into. Now, it's important, we don't want them to overly control their breathing while they're exercising. You know, there's an element of where they've got to trust their respiratory center, trust their body to know what to do. But just to give them a little bit of an insight is that to try not to let it run away with itself too much and get that good biomechanical rib cage movement, as I said. So using the nose, some sports allow this, some not. And I suppose the other thing is making sure that there's no breath stacking going on. So making sure that there's a nice active expiration where, you know, the lungs are coming, you know, there's a full expiration, the diaphragm's up coming back into its relaxed position, so it got a nice drive down again. I think when there's a very fast breathing pattern, often there's not a full expiration. So using pursed lip breathing to help sort of that expiratory phase to get the diaphragm in a good position to contract again, and taking the pressure and the tension away from this upper chest is absolutely essential. It's important to say not to overforce the expiration. So we need to be careful with some of these techniques that you do with the athletes, and you work out what's right and what's wrong as they're exercising and you're working with them. but it's really about slowing down that breathing on the in and relaxing the throat within the capability of still being able to exercise at high intensity. So let me just see if I can play this, which you might just notice the difference to the last one that I played. So can you see the inspiration is just a little bit more controlled, and this is something that we'd work on quite a lot with the athlete to really get a nice rhythmical breathing pattern when they're working you know, an appropriate exercise intensity. And I should just add the use of muscle inspiratory trainers. So an inspiratory muscle trainer may be appropriate for athletes with breathing pattern disorders, but you have to tread really carefully. So often what we don't want to do is to load up the diaphragm too soon when they're not biomechanically breathing well. So it can be disastrous for those athletes that are in that upper chest breathing pattern, because that may aggravate that. So I might use a muscle inspiratory trainer to load the diaphragm, like just a little bit, to give them a little bit of feedback, but I would be watching them really closely to make sure they were getting a good pattern of full inspiration and full expiration before I tweaked up the you know, the resistance on the inspiratory muscle trainer. So it is a nice adjunct to be used, it just needs to be used correctly. So that's kind of the tip on helping your athlete to breathe well, both at rest and during exercise. But I kind of want to come back to this rest thing. I want to talk to you about the recovery between training sessions. And I think this is absolutely essential for those athletes that are struggling with recurrent chest infections, or maybe trying to recover from the COVID virus, in terms of enabling their body to relax and recover. And what this slide is, this is a slide from some work we did with Respiratory and Optimal Life and Ground and Air. And what it is, this is a time scale. So so you've that bit in the middle there, you've got for in the daytime and then the evening, and the red is representative of the sympathetic nervous system. So we were measuring these with first beat heart rate variability monitors. And the idea is that I wanted to present to you what it should look like, first of all. Okay, so, you know, sympathetic nervous system active during the day, and then nighttime you see that lovely green parasympathetic nervous system in place that enables the person to recover, recuperate, and be ready for the next day. And you'll see there that lovely heart rate variability score of 125, which shows that, you know, nice high heart rate variability shows a good recovery, doesn't it? Because the beats, the time between the heartbeats, you know, is very variable. That shows the parasympathetic nervous system is dominant, in comparison to a lower heart rate variability where the heart rate is almost, you know, it's like a metronome. And that tells us the sympathetic nervous system is more active. So one thing that I wanted to present to you today is this is someone who is 10 months post-COVID, and pretty much they have a really poor breathing pattern and no inability to really physiologically relax. Now, this person did actually say that they slept okay for 6.5 hours, but can you see the overactive sympathetic nervous system that we're seeing here? Even though they're asleep, they've got no recovery, they've got no recuperation. The parasympathetic nervous system is really not being able to do what it needs to do to help the person to recover. And you can see their fairly low heart rate variability of 28 demonstrates that. Now, as a physical therapist, I often teach athletes how to influence their parasympathetic nervous system. And for me, there's two ways. One is through breathing and one is through relaxation. And so I'm often getting the athletes to really look at what do they do to physiologically relax. So they might say to me, I play an Xbox, I watch Netflix. I'm like, that's not relaxing. Okay, what I mean is, are you actually physiologically relaxing to enable recovery? So getting them to really do nice nose, tummy, low, slow breathing, and getting a physiological relaxation can really promote the parasympathetic nervous system. This is crucial for them to be able to recover between their sessions, but possibly even recover from the effects of the COVID virus too. So how do we get your athlete to breathe better? Well, so initially you've got to make sure they breathe well at rest. As I said, nose, tummy, slow, quiet breathing, absolutely essential. And then while they're exercising, you've got to make sure there's really good biomechanics of the rib cage, the diaphragm's working optimally, and you're able to get a rhythmical, good breathing pattern while the person is exercising. And then also looking at the recovery, making sure that your athlete is breathing well, using breathing as a tool to really promote their parasympathetic nervous system in being able to sleep well, recover between training sessions, and be able to get up and perform and train the next day. So if you've got any athletes that you think might benefit from our services, I'd be delighted to be able to teach them, you know, how to breathe properly and optimize their performance. So please do refer your athletes up to us at the Institute of Sport, Exercise and Health. There's details there, and I'm sure as the day goes on, you'll be fed that information too. Thank you very much.
Julie, thank you very much indeed. Already the chat line's going super hot, so I know there's loads of different questions. It was a great talk, thank you. So let me try and take these in some sort of an order, and I suppose the best place to start is with the diagnosis. And you know, what are the sort of strategies that you think help people to make a diagnosis rather than just simply waiting to sort of arrive at it as a default because every other test has been negative?
Yeah, it's challenging. As we've said before, the subjective history does tell you a lot about, you know, the potential differential diagnosis, but clearly not conclusive. And if you haven't got access to all the investigations, it can be tough. I'm a great fan of the BPAT tool, the breathing pattern assessment tool. It's a really nice, neat way of going through. It takes about 2 minutes to go through the patient's breathing pattern, and it guides you through, and if they score above a certain level, then it's indicative of them having potentially a breathing pattern disorder. But you're right that we struggle with objective measurements with this, which is why we've often struggled with getting some really decent research into the effectiveness of our treatment, because the diagnosis is really quite challenging, and you know, the range of causes of breathlessness and you know, the range of causes of breathing pattern disorders are so wide and varied, whether it's because of biomechanics, whether it's biochemistry or psychological. Do you know what I mean? There's so much going on that it's really quite hard sometimes to pinpoint.
Okay, great. So let's move on to the treatments. I mean, I'm sure people have seen there's about 10 different books now entitled Breathe. There's Wim Hof, there's Buteyko methods. Talk a bit about maybe the role of Buteyko or how it may overlap with your practice. Lots of people are familiar with some of those techniques.
Yeah, there's a few different ones out there. Like you say, the Buteyko, the Bradcliffe method, and the Papworth method, and they overlap a lot. And I think that the importance of it all is that the main thing for me is that making sure that the breathing pattern is normalised. So I'm always a little bit wary about breathing patterns that make you change the normal biomechanics of breathing, so whether you overbreathe for a period of time, or so I'm a little bit wary of those. Whereas the Buteyko, the Bradcliffe, the other ones, they're basically very much saying the same thing. The Buteyko tends to be a little bit more controlling, so there's a lot of things where there's some breath holding, and there's a lot of timing goes on. So that's sometimes some athletes do respond to that. So or different patients, different people. Some people like being told what to do with their breathing, whereas other methods tend to come from sort of inside and how the person feels and the sort of reduced breathing technique. And so I'm a Buteyko trained practitioner. Bradcliffe, I've done them all, you know, you can't help yourself, can you? I want to know them all, and they massively overlap. So often I'll just pull on different techniques depending on what the person needs. But I think the key thing for me with all these different methods out there is really it's about normalising breathing. Keep it normal, don't do any weird stuff.
And certainly, not sellotape up the mouth at night?
Oh no, I have had that. Maybe it's not sellotape, but some patients I have been known to turn the tape up their mouths, and I would do it in a really sort of a method where you just put slightly a bit down the sides, just in case anyone's going there. What is she doing? And so there's space at the sides, but you tend to get them to practice it during the daylight. The thing is people don't realise how much they open their mouths, and I think they think they've got their mouths closed, but they haven't a lot of the time. So a bit of tape just reminds them. Doesn't stop them completely.
So one of the things I hear from athletes is that the problem they get is when they're exercising and then they're taught how to breathe at rest, and then they come back and say, well, resting and breathing wasn't a problem ever for me. It's when I exert myself, and particularly in the context potentially of ILO. How do you tackle that? What do you say to athletes when it's breathing in exercise?
It's really common, isn't it? Because they feel their symptoms while they're exercising, and there's you trying to fix it at rest. And we've got to make sure that it does transfer up. But as a physical therapist, for me to get the biomechanics of a breathing pattern right with the patient, we've got to unload it. So I think education is massive. They've got to be patient, which can be tough. They've got to remember that there is a process. So often I'll explain the whole picture to the athletes. So I'll guide them through really explaining, right, this is what we're going to do at first, and this is the reason why we're going to fix it at rest, and then this is what happens when you stand up. That's what should happen to your breathing. Then when you walk in, that should happen to your breathing. Then when they're doing their sport, this is what should happen. So I think you've got to keep talking to the athlete, to keep referring back to make it specific for them, depending on how they're breathing with their sport. You've got to be careful not to go too quickly into that, but at the same time, I often do have athletes, they're so desperate. It's like, okay, we can look at this and help and give those techniques, especially, if they're still, they will be still training and competing, then giving them techniques to help with that alongside the breathing at rest, I think helps a lot to reassure them that this will come in. But I think the biggest thing is it does take a bit of time. It takes repetition to change biomechanics, and it does take time. And often that time is better done at rest than it is maybe during the activity or the exercise.
Okay, and just returning to a point you made earlier on about the BPAT, how can people access that, or are there links, or we can probably put a link onto the system here for that.
Yeah, I think it would be great if we could, because I think if you're not familiar with looking at the different components of breathing, it does really guide you through that very simply. So I think it would be really good, as long as I'm sure the team that produced the BPAT would be happy with that, then I think that would be great to share that.
Okay, fabulous. So final question really before we close for lunch. Dealing with young athletes who are growing, they've got growth spurts, they might have musculoskeletal issues or pain and other things associated with that time of their lives. But how do you unpick that group of individuals, specifically the adolescent who's got dysfunctional breathing?
Yeah, adolescents, I find, especially athletic adolescents, I think often I'm talking to them about their sleep and about their relaxation. They're a little bit they can be a little bit hypo and things. I think that's a part. But you're right, posture. I know it just reminds me how bad some of the posture in athletes, adolescents probably more so. So I'm often doing a lot of work with them in terms of their posture to make sure that as they grow, that they're not going to create this, sort of forward-leaning tight pecs that then leads to that sort of, the restriction in their breathing pattern, especially if they're in a cycling or rowing position for long periods of time, and then they sit for long periods of time. So again, education on posture so that they grow into a good position is really important, isn't it?
Yeah. Okay. Well, listen, we could talk to Julie all day long, and I'm sure you've got her contact details, and she'll help with anyone who hasn't had their questions answered. But it only leaves me really to thank all the speakers for this morning's respiratory session. All over the world have contributed, and the talks will become available later on, and especially the talk from Martin Schwellnus, which I apologise again for the lack of sync with the voice and slide feed. So we'll send that through. Thank you very much as well to the ISEH for organising and hosting this, and the people who arranged the pre-feed on that. We're going to have a break now, and then in the afternoon, we've got a fantastic setup of speakers, again, all from all over the world leaders talking about the issues you need to know about in terms of sports cardiology. in recreational and in elite athletes. So I'll let you go now. Look forward to meeting you at a start at 1:30 this afternoon. Thank you very much.